inflammatory bowel diseases, or IBD, Crohn's disease, and ulcerative colitis. Etiology is still unknown, most probably autoimmune. Genetic factor plays a great role. Environmental factor, the same. Infections, TB, measles, not confirmed. Psychological factor also plays a role. Then we have Crohn's disease, ulcerative colitis. Pathology. For Crohn's, it affects any part of the GIT, particularly the ileocecal region, in a discontinuous pattern. Scap lesions. Rectum is often spared, while ulcerative colitis, rectum is always involved, extending proximally to the colon in a continuous pattern. Terminal ileum can be affected in only 5%. Layers. For Crohn's, all 3 layers transmular with granuloma in 30%. Crypt abscesses are absent, while we have only granuloma. Fibrosis, severe. For ulcerative colitis, layers involved are the mucosa and the submucosa, no granulomas, but we have crypt abscesses in 30%, so the finding of granuloma is in Crohn's and the finding of crypt abscesses in ulcerative colitis. Fibrosis, not present in ulcerative colitis. Clinical picture. For Crohn's, it's equal in both genders, not specific age. Smoking, increased incidence in smokers. Abdominal pain is prominent. Diarrhea is present. Bleeding per rectum is uncommon. Anal and oral lesions are present, with bowel obstruction, malabsorption syndrome, intestinal fistula, and vitamin B12 deficiency, and there is minor carcinoma risk, with rare incidence of toxic megacolon to occur. While for the ulcerative colitis, it's slightly more in females from 30 to 40 years, decreased incidence in smokers, 80% of them are non-smokers, less prominent abdominal pain. Diarrhea is present, severe, and maybe bloody diarrhea. Mesmus, urgency, rectal pain, and fecal incontinence are common. Bleeding per rectum is common, while anal oral lesions, bowel obstruction, malabsorption syndrome, intestinal fistula, and vitamin B12 deficiency, all of those 5 are absent. Carcinoma risk, high, significant risk 2 to 3 decades after the onset. Toxic megacolon occurs. It's a condition in which the colon becomes atonic, dilated, more common in ulcerative colitis as we have mentioned. Worsening of the patient, clinical conditions, and development of fever, tachycardia, leukocytosis, treatment, antibiotics, and prompt surgical consultation. Extraintestinal manifestations in both skeletal, peripheral arthritis, seronegative spondylopathy, ankylosing spondylitis in 30% of the cases, osteoporosis secondary to disease process itself, or medications commonly used for treatment such as corticosteroids. For skin, we have erythema nodosa, painful red subcutaneous nodules, pyoderma gangrenosa, ulcerated lesions, aphthous stomatitis, shallow tender ulcers in the oral cavity, liver, fatty liver, sclerosing cholangitis, lung, interstitial pulmonary fibrosis, eye, episcleritis, scleritis, and uveitis. Investigations. For Crohn's, for radiological, we find deep ulcers, cobblestone, areas of narrowing in the ileum, scap lesions, fistula and strictures, colonoscopy and biopsy, involvement of the entire bowel wall with granuloma and positive ASCA, anti-Saccharomyces antibody, PhilCam imaging. For ulcerative colitis, rigid colon with absence of hastra, lid pipe sign, pseudopolyposis in 15%, limited to the mucosa and may have crypt abscesses. P. ANCA and ASCA are present with fecal calprotectin. Yes, I'm right. Treatment, medical treatment. Sulfasalazine reduces inflammation, especially in ulcerative colitis, 1 gram per 6 hours, reduced to maintenance dose of 2 grams per day for 2 years after remission. Steroids, prednisone, 60 milligram per day. This is the main treatment for active disease. Immunosuppressants, elastoprine. Symptomatic antibiotics for secondary infection, metronidazole and ciprofloxacin. Prebiotics, probiotics, antidiarrheal drugs. Surgical treatment indications, failure of medical treatment, and severe complications. And then we have malabsorption syndrome. Definition: failure of absorption of one or more of the nutrients, fat, proteins, carbohydrates, minerals. Steatorrhea, fatty stool, remains the main mark for malabsorption. Causes: gastric, hepatobiliary, pancreatic, and intestinal. Gastric causes: gastrectomy, atrophic gastritis, cancer stomach, leads to a chlorhydra, decreasing the HCl, bacterial contamination of the intestine. Or Zollinger-Ellison syndrome, hyperchlorhydra, inhibits pancreatic lipase. Hepatobiliary causes: chronic hepatitis, biliary fistula, biliary obstruction, and liver cirrhosis. Pancreatic causes: chronic pancreatitis, cystic fibrosis, pancreatectomy, cancer head of the pancreas. Intestinal causes: this is the most common: Primary causes: tropical sprue, unknown etiology but maybe bacterial, viral, parasitic infection or folic acid deficiency. Celiac disease: non-tropical sprue, gluten-sensitive enteropathy, autoimmune disorder in which there is abnormal reaction to gluten, antigen-antibody reaction leading to damage of the intestinal mucosa. Clinical picture: severe malabsorption syndrome, associated autoimmune diseases. Complications: small intestine carcinoma, increased incidence of lymphoma. Investigation: jejunal biopsy, villus atrophy, IgA antigliadin antibodies. Treatment: the only effective treatment is lifelong gluten-free diet. Secondary to intestinal diseases: short gut syndrome, extensive intestinal resection leads to absorptive surface decrease. Stagnant or blind loop syndrome, stagnation of intestinal contents, structure of the small intestine, diverticulosis, bacterial overgrowth, mucosal injury, and finally nutrients utilization. Systemic diseases: diabetes, amyloidosis, hypothyroidism, and chronic heart failure. Infection: bacterial overgrowth, TB, enteritis, giardia, and strongyloids. Inflammation: Crohn's, irradiation, iatrogenic, antacids, biguanide, cholestyramine, and dindivan. Lymphatic obstruction, lymphoma, Whipple's disease, mainly affecting man. M for malabsorption syndrome. A, arthritis. N, neuropathy and lymphadenopathy. Clinical picture: general manifestations: loss of weight, fever, fatigue, clubbing of fingers. Intestinal manifestations: Diahrrea, stool is pale, bulky, offensive, floats on water, greasy, glistening. Diarrhea, malabsorption usually results in diarrhea, audible intestinal sounds, and finally distension and colic. Nutritional deficiency: hypoglycemia, loss of weight, muscle wasting, edema, and recurrent infections. For iron: anemia, sodium, muscle cramps and hypotension. Potassium: arrhythmia, calcium, magnesium, tetany. Iodine: goiter. Vitamins: decreased A, night blindness, follicular hyperkeratosis. D, rickets, osteomalacia. E, infertility. K, bleeding tendency. C, scurvy. B1, beriberi. B2, glossitis, gastritis. B3, diarrhea, dermatitis, dementia. B6, peripheral neuritis. B12, megaloblastic anemia. Clinical picture of the cause: celiac disease or history of surgical operations. Investigations: we have 4 biochemical investigations, hematological, radiological, and 4 bacterial overgrowth. Biochemical investigations: estimation of fecal fat, normally it's 6 grams per day. In steatorrhea, total fat is increased more than 6 grams per day. Split fat, intestinal disease, non-split fat, pancreatic disease. Pancreatic function tests: sugar curve, flat curve. D-xylose test: 25 gram D-xylose. Poorly metabolized sugar is given orally, then collected in urine over the next 5 hours. Normally 5 hours urine should contain at least 5 grams provided that normal renal functions. In malabsorption syndrome, 5 hours will contain less than 5 grams in the urine. Hematological investigations: blood picture, anemia, microcytic anemia due to iron deficiency or macrocytic due to vitamin B12 deficiency or folate malabsorption. Plasma proteins, hypoproteinemia. Serum electrolytes: prothrombin time may be prolonged because of malabsorption of vitamin K. Radiological investigations: ultrasound, CT, MRI, barium meals, dilatation of intestinal lumen, loss of normal feathery appearance. Investigations for bacterial overgrowth: 14C xylose breath test, given orally, then measure the 14 carbon dioxide in the breath. In bacterial overgrowth, increased 14 carbon dioxide in the breath because more bacteria will act on the 14C xylose. The gold standard test for SIBO, small intestine bacterial overgrowth, is small bowel culture. Treatment of the cause: TB, enteritis, anti-TB drugs, tropical sprue, antibiotics, tetracycline, and folic acid. Celiac disease: the only effective treatment is lifelong gluten-free diet and cortisone. Diet: low fat, low fibers, non-irritant diet, parenteral vitamins, minerals, fluids. And finally, symptomatic treatment: antidiarrheal drugs such as diphenhexylate, loperamide. Diarrhea. Definition: increased stool liquidity, quantity, and frequency. The water content of adult stool is more than 60%. The maximum absorption of fluid in GIT occurs in jejunum. Etiology: we have etiology for acute diarrhea and etiology for chronic diarrhea. For acute diarrhea, acute onset within less than 2 weeks of symptoms, is generally infectious and self-limited. Infections: bacterial, Salmonella, Shigella, E. coli, and cholera. Then we have viral: rotavirus, Norvac virus, protozoa, E. histolytica, malaria, giardia, helminths, ascaris, and strongyloids stercoralis. Organisms that cause bloody diarrhea include Salmonella, Shigella, E. coli, and Campylobacter. Diarrhea after ingestion of raw eggs or dairy products. think about salmonella, where the most common etiology of infectious diarrhea is Campylobacter. Iatrogenic, laxatives, antibiotics, chemotherapy, parasympathetics, magnesium hydroxide and allopurinol. Magnesium hydroxide leads to diarrhea. Aluminium hydroxide leads to constipation. Toxins, bacterial, staph, E. coli, lead, arsenic. Diet, unripe fruit, alcohol, mushroom, and food allergy. For chronic diarrhea, we have gradual onset with more than 4 weeks of symptoms, malabsorption syndrome with its causes, diseases of the colon, irritable bowel syndrome, inflammatory bowel diseases, ulcerative colitis, and cancer colon, endocrinal causes, cytotoxicosis, diabetic neuropathy, Addison's disease, Zollinger-Ellison syndrome, carcinoid tumor. Mechanisms of diarrhea, osmotic diarrhea or malabsorption, secretory diarrhea, abnormality in intestinal motility or intestinal mucosa. For osmotic diarrhea or malabsorption, presence of non-absorbed hypertonic substances in the intestinal lumen, maintaining fluid and preventing absorption such as lactulose, sorbitol, and magnesium. Secretory diarrhea, watery diarrhea, increases secretion of water and electrolytes into the lumen, such as E. coli, cholera, increased VIPs, vasoactive intestinal peptides, abnormality in motility, cytotoxicosis, inflammatory bowel syndrome, and diabetic neuropathy, abnormality in mucosa, inflammation, inflammatory bowel diseases, causes of bloody diarrhea, radiation colitis, ischemic colitis, parasitic, amoebiasis, bilharziasis, bacterial, Shigella, Salmonella, TB, E. coli, Clostridium difficile, and finally the most important one and the most common one is Campylobacter. Complications, decreased water, dehydration, decreased potassium, hypokalemia, decreased bicarbonate, acidosis with normal AG. Diagnosis, history analysis, frequency, more than 4 times per day means diarrhea if the stool is large volume and not excessive. Frequent, small bowel disease. If the stool is small volume with excessive frequency, then this means large bowel disease. Consistency, water, inflammation, greasy, malabsorption, color of stool, tarry, melena, pale, steatorrhea, bloody, ulcerative colitis. Relation to meals, osmotic, stops with fasting, secretory, continues with fasting. Associated symptoms, constipation, inflammatory bowel diseases, fever, infection, inflammation, nausea and vomiting, acute infections, abdominal pain, all causes of diarrhea except for the drug-induced and cytotoxicosis. Examination, we have abdominal tenderness, bowel sounds, degree of general hydration, and examination per rectum to exclude rectal masses or blood. Investigations, not every patient who presents with diarrhea needs to be evaluated with those tests because they are expensive. Acute diarrhea usually doesn't require laboratory investigations unless the patient has high fever, bloody diarrhea, or diarrhea lasting for more than 5 days. Stool examination for ova, cysts, and parasites. Fat assay. Stool osmolality or osmotic gap. The stool osmolality is 290, more than 50. Presence of more osmotically solutes in stool, such as lactulose. Sigmoidoscopy, if large bowel cause is suspected. Small bowel radiology, if small bowel cause is suspected. Serological tests, plus investigations of malabsorption syndrome. Treatment, 3S, specific, treatment of the cause, symptomatic, antidiarrhea, diphenogxylate, loperamide, antiemetic, motilium. Supportive, diet, decrease fat, irritants, light diet. Treatment of complications, fluid and potassium with bicarbonate. Acute pancreatitis, etiology, gallstones leads to obstruction of pancreatic duct, and this is the most common cause. Viral infections, mumps, Coxsackie B, alcohol, hypercalcemia, hyperlipidemia, idiopathic, iatrogenic, thiazide, post-ERCP, gallstones, back regurg of trypsin enzyme, autodigestion. Symptoms, nausea and vomiting, abdominal pain, epigastric pain relating to the back. Signs, unexpectedly, abdominal signs are minimal in comparison with the severity of the pain. Gray Turner's sign, ecchymosis in the flanks. Cullen's sign, umbilical ecchymosis. Tenderness and rigidity at first in the upper abdomen, later on it becomes generalized. Complications, MOF, multiple organ failure, heart failure, renal failure, respiratory failure, abscess, pancreatic ascites, hypocalcemia, DIC, diabetes, obstructive jaundice due to edema of the head of the pancreas. Poor prognostic indicators, the mnemonic is pancreas, PA oxygen, less than 60 mm mercury, A, age, more than 55 years, N, neutrophils, the white blood cell count is more than 16,000 per millimeter cube, C, calcium, less than 8 mg percentage, R, renal, urea more than 100 mg percentage, E, enzymes, LDH more than 350 and SGOT more than 250 units, A. Albumin less than 3 gram percentage, S. Sugar, glucose more than 200 milligram percentage. Investigations: pancreatic enzymes, elevated amylase in blood, urine, and peritoneal fluids. Lipase is also elevated, and it's more specific than amylase because serum amylase is raised in other conditions such as perforated peptic ulcer, ectopic pregnancy, alcoholics, and salivary gland diseases. Peritoneal aspiration contains high amylase. Blood picture: leukocytosis, anemia in hemorrhagic pancreatitis, X-ray, ultrasound, CT, gallstones, swollen pancreas, and calcification, ECG to exclude myocardial infarction. Treatment: nasogastric suction, IV nutrition, antibiotics, analgesics such as petidine. No morphine is used because it induces spasm of sphincter of Oddi. Somatostatin infusion. Treatment of complications: respiratory support, cortisone. Surgery for pancreatic abscess and ERCP may be needed. Prognosis: roughly 85% are mild and self-limited, 15% are severe requiring ICU admission. Mortality rate is about 50% of severe cases. Differential diagnosis for acute abdominal pain. For epigastric pain, we have esophageal spasm, hiatus hernia, esophagitis, cancer, gastroduodenal, gastritis, peptic ulcer, gastric carcinoma, gallbladder, cholecystitis, gallstones, pancreas, pancreatitis, cancer pancreas, hepatic, hepatitis, hepatoma, congested liver, CVS, angina, myocardial infarction, pericarditis, aortic dissection, chest, pneumonia, pleurisy, repeated cough, nervous system, herpes zoster, and neurosis. So in order to sum it up, just mention the organ with its inflammation and cancer. Medical conditions which mimic acute abdomen: myocardial infarction, rheumatic fever, dissecting aortic aneurysm, congestive heart failure, right upper abdominal pain due to congested liver, diabetic ketoacidosis, hypoglycemia, tetany, hyperparathyroidism, hemolytic crisis, Henoch-Schönlein purpura, acute intermittent porphyria, acute pancreatitis and renal failure, vasculitis, FMF, and irritable bowel syndrome. Acute pain in the upper abdomen, esophagitis, acute coronary syndrome, unstable angina or infarction, hiatus hernia, gastritis, gallstone, colic, acute cholecystitis, duodenal ulcer, gastric carcinoma, and pancreatitis. Acute central abdominal pain, small bowel obstruction, Crohn's disease, mesenteric artery occlusion, and abdominal aortic dissection. Acute lateral abdominal pain, pyelonephritis, renal calculus, ureteric calculus, appendicitis, salpingitis. Acute lower central abdominal pain or hypogastric, ulcerative colitis, large bowel obstruction, cystitis, and ectopic pregnancy. Constipation. Definition: presence of 2 or more of the following: hard stool, infrequent stool, less than 3 times per week, incomplete evacuation, straining is more than 25% of the time of defecation. Causes: we have 8 eyes, not 4 persons, but 8 eye letter, immobility, prolonged rest in bed, decreased intake of fluid and fibers, ignoring urge, irritable bowel syndrome, decreased intestinal mobility such as hypothyroidism, diabetes, increased calcium, decreased potassium, diabetes, and scleroderma, iatrogenic, codeine, morphine, anticholinergic, aluminum hydroxide, iron, inflammation, ulcerative colitis, diverticulitis, intestinal obstruction, cancer colon, stricture, and anal fissure. Approach to a case of constipation: history, dietary history, and fluid intake, medications and associated symptoms, examination, manifestations of the cause, PR examinations to identify fissures, hemorrhoids, which may be caused by constipation, investigations for the cause, serum calcium, glucose, thyroid function test, and then we have colonoscopy, especially in patients over 50 years with anemia, weight loss, bleeding per rectum, positive occult blood test, or family history of cancer colon. Treatment of the cause, medical and surgical, general, reassurance, diet, increase fluid and fiber intake. Laxatives: we have bulk laxative, fiber-based laxative, osmotic, lactulose, stimulant, senna, I don't know what this means, softener such as mineral oil, and this concludes our part for today.